Hello, everyone, and welcome to another edition of FitRx. I'm your host, Dr. Greg Dennis. I am very excited today about my next guest, Dr. Christy Kesslering, MD. She started out as a radiation oncologist, which I don't believe I've had an actual oncologist on the show, so again, very excited about that. She received her undergraduate degree from UCLA and medical school at Loyola University in Chicago. Again, worked as a radiation oncologist, and now, which we will hear her story, but she has been trained in functional medicine, integrative medicine, the terrain theory of cancer, and so she has worked with Dr. Nasha Winters, who has been on the show before. And so I'm just, really excited to kind of hear about her evolution, coming from the traditional oncology background to what she does now. And so, Dr. Kesslering, thank you so much for being on the show.
Hey, thanks for having me. It's great.
Well, anytime I have a physician on here, especially like you, I always kind of ask them about how they got to, what you're doing now. And on your website, you talk about metabolic health, which, you never hear from, more quote, traditional doctors. And, uh, I, again, like I mentioned in the intro, I don't think I've had an oncologist. And as we were talking beforehand, it's so difficult to find an oncologist that's, quote, more integrative. So I guess tell us about your journey, about how you know, saw the light, as I call it,
Mhm.
but, was more of a traditional, assuming a more traditional radiation oncologist to, how you start questioning things and just about that evolution as far as what you do now.
Yeah, so I've been a radiation or was a radiation oncologist, started in my conventional practice back in 2000. I always felt like I was a little bit of an early adopter of technology and different fractionation schemes and always trying to do less is more. So I was always one of the early adopters of can we give less treatment or more targeted treatment or shorter courses or, all of that. But I guess my metabolic health journey began with myself. I think a lot of us find that. But back 24 years ago, I started following a low carbohydrate diet. I had, I always struggled a little bit with my weight, had two babies, was trying to take off baby weight, trying to get pregnant again, not really great, great success. And so anyway, I just decided I'm going to get my health back. Atkins was kind of the thing at the time. So I did low carb diet. I thought, oh my God, this is so easy. And in the beginning, to be honest, a number of my nurses had asked me about it, and I spouted the same old concerns that we hear from our conventional docs. You're going to kill your kidneys, you're going to kill your heart. That's crazy. I decided to read his book and actually read some of the studies and read really kind of the biology behind it. And I'm like, this guy makes a lot of sense. I'm like, I'll try it for myself. And that's one of my classic things is I really try a lot of things on myself before I start recommending them to clients or patients. Um, but anyway, so I found that and okay, wait. Well, in cancer, and I was doing a lot of breast cancer and a lot of endometrial cancer, and those are very classically associated with obesity. So I thought, well, why can't I use some of my successes to help my obese patients? And hey, have you ever thought about carbohydrate restriction? And I would kind of always throw out diet and how do you want to do it and refer, to a couple of books and there were so many different diet books along the way that kind of advocated for a lot of the similar things. But it wasn't until, God, I want to say 2017 maybe that I happened upon and you kept seeing the reflections like, oh, Alzheimer's, type 3 diabetes. Wait, it's about sugar, all of these things that were linked more to sugar than really obesity, right? Type 2 diabetics don't have to be obese. Cancer patients don't have to be obese, but I came kind of in that 2017 starting to understand and learn more about kind of that metabolic dysfunction, mitochondrial dysfunction, the terrain theory, of cancer. And so I started to go down some of these roads, educate myself, and really kind of buying into it's not just about carbohydrate restriction, but it's about really optimizing metabolism, really potentially using ketogenic diets where we're really pushing on fat burning. But when you're in conventional medicine and you're part of big cancer centers, you have cancer dietitians who do not believe the same things that you believe. And so as some patients were very in tune and absolutely bought in, and I will do this during radiation, but then they would kind of fall off, or they would be basically doing something that the dietitian was telling them not to do, or so there's a lot of conflict there. So I decided that I should, get more educated, had maybe some letters behind my name that kind of supported my recommendations, or at least that my credentials for recommending those types of things. And I did some online functional medicine. I joined the Andrew Weil, integrative medicine. And to be honest, I was about halfway through the program and I'm like, they don't understand metabolic, health. They don't understand mitochondrial health. They're kind of saying the same thing that conventional medicine is saying, just with supplements instead of pharmaceuticals, but they were advocating for the same diets and the same, eat less, move more, and that kind of thing. And I'm like, this is not right. And I had already, Nasha and I met in 2018, and I knew she was starting the program, but at the time I didn't think that was the right avenue for me, still being in conventional medicine. But as I'm getting to the point now where I'm like, I think I'm ready to leave conventional medicine. I need to do this full time with the people who are wanting the information, that are willing to do the work, because it's work. You have to swim upstream and fight against conventional recommendations and things like that. And so I decided to kind of jump ship and go straight into Dr. Nasha's program, and do more in that regard. And so become a part of that family. And now I'm one of the educators in her program as well. And it's been a real journey, but it's been extremely rewarding because, again, in conventional medicine, where I was kind of, bucking the trend, and not that anybody was, quote unquote, upset with me for trying to help patients. And I had administrators very much supporting my recommendations. I actually ran a patient support group monthly for 6.5 years in conventional medicine, because their cancer resource center, their life enrichment type center that was called Living Well, they said, we are not diet agnostic, or they are diet agnostic. They don't want to say that you have to do it this way or the highway. They were trying to give lots of different options for patients so that they could find their place. So they always supported me helping patients, giving talks, doing little mini challenges and trials, and it was really nice, except that it still wasn't exactly what I wanted, because it was such a small group. When in conventional medicine, a lot of people walk in and like, don't you have a pill for that? Like, no, you have to change what you're eating or doing, or how you're sleeping, and like so much of our lifestyle is like counter to how we really should be living. And some people don't want to do the work. So anyway, it's been really fun in that now my whole career is helping the people who want to be helped, trying to educate them. And again, it's very hard when you're hearing lots of different voices saying different things, and how do you sort through that noise? And so I really try to be a sounding board, and I don't dictate necessarily. If somebody says, listen, Dr. Kesslering, I really want to try a vegan diet, or whatever, I'll say, you know what? That's completely up to you. This is why I would caution you against it. But if you really want to try it, then let's run labs before you do that. Let's run labs after you do that, and let's see what changes. And so many times they're like, oh yeah, that was a bomb. Okay, that didn't work out. My insulin's through the roof. I don't feel as well. My gut's wrecked, whatever. So again, some people feel good initially doing those very restrictive diets, but really because they're cutting out some of the crappiest foods, a lot of the processed foods, things like that, when they're really concentrating or prioritizing those real foods. I think anytime somebody switches from a fake food, to a real food diet, we're going to see improvements. But then it's like, what's best for the long term? What can we do to improve metabolism, nutrient status, gut health, etc.
Mhm. When you were still in conventional medicine and recommending a lot of these things, what were your colleagues saying to you? What was that like?
Well, interestingly, some colleagues sent their patients to see me. I was seeing administrators and other staff members in the hospital system as I started practicing even outside of oncology patients then. But I had some that said, I don't believe what Dr. Kesslering says. I think you should say this. I had some that said, I don't want Dr. Kesslering seeing my patient because she will, or they would tell me, you're covering for me next week, but please don't bring that up. So sometimes you have to go like you knew. And it's funny because sometimes the patient would say, oh yeah, wait, I'm doing a ketogenic diet. Don't tell the doctor. I found it on my own, like brain tumor patients that were, having seizure, like, oh, we found this online, but he said, don't do it. So we're just doing it without telling him. And I'm like, well, I think you're on the right track, so at least they had somebody saying that they were doing the right thing. And, you feel bad sometimes. Sometimes you'd say, hey, I'm not telling you what to do, but you might want to look into this person or this website or this, you kind of throw them, if you want to, if they don't want to hear it, they won't look at it, right? But if somebody is really, I think it's tragic that when somebody says, I want to take an active role in my cancer journey, and then they're told there's nothing you can do. This is just
Mhm.
bad luck, genetics, whatever. Like you aren't in control. And that's where I think the real tragedy is.
Yeah. I've asked other physicians this question, but why do you think that not more doctors can kind of see the failures of the more conventional medicine and I guess see the light? Because it seems like it rarely happens. And I was fortunate enough, I'm a primary care doctor, and I was fortunate enough that it happened to me. I had a huge panel, and I just again, I literally feel like the veil was pulled from my eyes
Mhm.
and I was like, I'm doing everything that I was taught to do, but the patients really aren't getting any better. Like there's got to be more to this. And then that took me on a deep dive and a whole lot of deep dives. And um, but so many doctors, and I feel like specialists are even worse. They just, they're so tunnel visioned and they don't want to hear anything else. Why do you think they can't take a step back and look and be like, maybe there is some better
Yeah.
ways?
Yeah. So number one, I think um, they don't think they're doing a bad job. I think they think they're doing a great job, and we come out with these new medicines that have this. So then we help the people that didn't respond to that. And I think so I think one thing is that they don't think they're doing a bad job. And I'm not saying that they are doing a bad job within the context of what they do and their tools that they have. But I think what my next level is they're swamped. They're busy. They're just trying to get through their day. And now you want them to go down this whole rabbit hole of information, and it's a lot of self-education. It's not out there, right? You have to seek it out. You're not spoon-fed. When you go to your national meetings, you're just told about more treatments and more medicines and more. It's never about less. It's rarely about diet. Every once in a while, one of those sneaks in, and sometimes it's quite interesting. But guess what? The doctors choose not to go to that one. I don't need to go to the diet one. That's why I have a dietitian, you know. But then the dietitians are trained very traditionally, and sadly, when you look at a radiation oncology meeting, who pays for that radiation oncology meeting? Treatment machines, companies that make machines, companies that make drugs. So when you go to a medical oncology meeting, it is paid for by pharma. I mean, that's who donates money to run the thing. So I feel like all of the national meetings, for the most part, are paid for by the medical device, medical pharma industry. So I think um, that's what they're looking at. It's very hard to do diet trials. It's very easy to do a treatment trial. Come on in, we'll inject you with the drug, we'll treat you with radiation, or we won't, or we'll do it this, way A or way B. But to do a diet trial, who pays for that? Who would get money for that? Who is going to monitor the patient 24/7? Like that's a lot of ask on a patient, and then it's a lot of ask to do all that when you don't have a big money person funding it. So I just feel like they're very hard to do. So then our doctors will say, oh, there's just not enough data. Well, can we at least take the data that we have to the level that we have it and say, at least it's not going to harm you. So I usually counsel, my clients to, if they get asked, say, listen, I just cut out sugar and junk food. I mean, those are true statements. I'm eating a lot of real food. I'm eating fish and vegetables and meat and, whatever. And to be honest, sometimes I have people on carnivore diet. So, but I, again, usually just say, just tell them that you decided to eat better or that you're, and now you're working out. You haven't worked out before. And sadly, what we know is that it's not about weight loss. It's about unintentional weight loss, right? And it's not about, inflammatory fat mass loss. It's about lean mass loss. So the people who don't do well are those who unintentionally lose weight and lose lean mass. And so when we follow ketogenic diets, we tend to lose inflammatory water weight, we tend to lose fat mass, we tend to improve body composition. So I feel like we are definitely supporting patients. And so we just have to let them know that not all weight loss is the same. And you're not at risk for having a worse outcome if you lose weight that is intentional and done properly. Not just that we're calorie restricting and we are losing fat mass and lean mass. And if somebody feels like they are losing too much weight, well, how do we optimize your diet to not lose weight, right? Eat more calories, eat more food, because sometimes you don't have the appetite, or maybe your chemo is coming more often than every 3 weeks and you think you should be fasting, because we do use fasting around chemotherapy. But I don't want people fasting 5 days a week every week. And I actually had somebody who was doing that. And she came to see me and I'm like, oh, your labs, you are so nutritionally depleted. You're essentially cachectic and everything else. Like, what are you doing? And then come to find out I don't know if she was doing 5 days a week, but she was doing at least 3 days every single week. And on the days she was eating, she was barely eating any calories. And I'm like, that's one way to lose weight, because she was overweight. I said, but that's not really the best way to lose weight. And so sometimes it's just educating the patient that, and again, it's in our space. It's in the other spaces, like, what are we being told? What's the data behind it? I try to just be a voice of reason and not a dictator as to what you need to do. But like, let's see, where did that data come from? Or where did that recommendation come from? What was the level of data? What do we know? What don't we know? I think even within the ketogenic cancer space, there's a lot of things that are said that I don't know that we know that. And yet we're saying it as if that's been proven. So I just think we have to be cautious, and we have to take the patient's situation, cancer therapy choices, all of those things into consideration as we're working through doing our best to optimize their own health while they're in a tough situation.
Sure. I want to talk a minute about cancer prevention. It seems like that cancer continues to be on the rise. I've even heard a stat, which maybe you can, validate, that in 5 years from now, 1 in 3 people will get cancer in their lifetime. It just seems to be getting more and more prevalent. And so, first part of that question is why are we seeing continuing to see so much cancer? And then the second part of that question is what can we do to prevent it?
So I think the whys are still theoretical, but I mean, I certainly believe that our food environment is a big one because, as we know from kind of national studies, is that there's almost nobody left that's metabolically healthy. We're in the 2 to 5% range of adults that are truly metabolically healthy. So if we are assuming or believing, as I do, that cancer is a metabolic disorder, and nobody's metabolically healthy, it's just a matter of time before we develop cancer. So we talk all the time in our world that insulin and IGF-1 are growth factors for cancer. Insulin, what is that? That's a response that our pancreas or our pancreas responds to a glucose load, a carbohydrate load with an insulin response. What we know is that when that happens over and over and over and over again in our high carbohydrate diet world, that we become insulin resistant, which now our pancreas is producing insulin 24/7, at higher levels than what we would normally see. And what we know is that diabetics have higher rates of cancer. Obesity, which really is a disease of high insulin. Insulin grows fat cells. So obesity is a sign of high insulin. Obesity associated with much higher rates of cancer. So I think we have to understand insulin. And I wish that our primary care doctors, right, we're so glucose centric that we never look at insulin. But if we started drawing insulins, and as insulin starts rising, we now tell patients, you already have a sugar problem. Even though your glucose looks great, you have a sugar problem. So I think that's a big one. I think that just our fake food, processed food, like we are not getting nutrients. So then we just keep eating, which again compounds the glucose insulin problem. I think that our change in fats from very natural, fats like tallow and lard and butter and moving to the industrial fats, the seed oils, soybean, corn. There's a lot of animal literature that shows that soybean oil, corn oils grow cancer, but palm oils and coconut oils tend not to. So I think that the fats probably have some element of mitochondrial dysfunction that then creates cancer. I think that our light environments, our sleep environments, our 24/7 go environments, I think they all predispose us to cancer. And so I think the best thing that we can do to prevent a cancer is to not wait until we get sick. I say any diagnosis is your check engine light going off. Oh yeah, my glucose is a little bit high. I feel great. Or my blood pressure is a little bit high, but I feel great. My whatever. And I hate to use some of those conventional tools because again, we could question a lot of what we know as conventional doctors. But I do think that if your joints hurt or you don't sleep well through the night or you're working, burning the candle at both ends and working 15-hour days and you don't do enough rest and repair, I think you're setting yourself up for trouble. So my bias is get a set of labs. Like you said, you got a big panel of labs and you saw some abnormalities there and you're like, wow, I had no idea that I was on this path. And so if we get information sooner rather than later, and then we can see kind of like, hey, if I don't fix something now, I'm going to have a problem later. And I kind of say, I think genetics do play a role in that I'm going to have a metabolic dysfunction. What dysfunction is that going to drive? Diabetes, cancer, both, Alzheimer's, so familial patterns certainly are probably environmental, but I do think that if, dementia runs in your family, it's not that you're predisposed to have dementia, but if you don't mind your mitochondrial health, you may very well get dementia. So I think all of those things are so interesting and interrelated, but I just think we have so much that we could do. But very commonly, we don't do anything until we get sick.
Yeah, for sure. Yeah, certainly metabolic health is a big one. When you start looking at the kind of the toxic soup of an environment that we live in, the air we breathe, the
Yeah.
water we drink, the cosmetics that we use,
Yes.
all of those things, it can almost be overwhelming for people. I mean, I'm like you, I study this stuff, and sometimes it's just overwhelming to me. You just want to throw your hands
Yes.
up, but
Yeah.
like, nothing we can do. Do you kind of go down all those rabbit holes with people about just cleaning up other parts of their life other than, diet and metabolic health? And what do
Yeah.
you feel like are some of the I guess the big, maybe carcinogens out there, maybe unrelated to metabolic health?
Yeah. I mean, I think that they impact metabolic health. So I think that if your metabolism is great and you're bringing in great nutrients and you're not bringing in the toxins in your foods, then your ability to detox other things improves. Number one. But again, if you've removed grains and processed carbohydrates, you've removed a lot of like the glyphosates and the some of the toxins that are in the seeds of plants, the grains, legumes, nuts and seeds, I feel like are also problematic. But yeah, I ask patients, do you filter your water? Do you use conventional products? Do you store and or heat in plastics? Do you use Teflon coated pans? So we're always trying to get that thought out there. And I think there's some pretty good books that I do direct people toward. I don't spend a lot of my time on that because I feel like there are great resources out there. I just say, but sometimes I will run a toxin panel. Like, guy, it just seems like you've got something else going on that's not clearing. Like, might you have mold toxins or heavy metal? So we'll run a toxin panel. We might run a gut panel. We might run whole hormone panel, although I'm not advocating for hormone treatment, but how do we best balance hormones? Does it give us some clues? Um, yeah, again, I always come back to diet and nutrition because I do feel like if we focus on that, other things tend to fall into place. Like you're so like, well, now I care what I'm putting into my body. I should care what I'm putting onto my body, that my skin eats, what I put on to it. So um, we do touch on all of those aspects. I usually give kind of a lifestyle handout, trying to hit on toxins, sleep, stress, exercise, some of those other things that aren't just about the diet piece.
Um, Talk about, if you will, tell us about your kind of day-to-day lifestyle. I mean, you're somebody who teaches this stuff. You're an oncologist. So knowing what you know, share with us kind of like maybe
The things that I do.
a little glimpse of your daily routine, maybe how you
Yeah.
eat, exercise, just, things that you feel like are kind of important to you.
Yeah. So I definitely follow a low carbohydrate, high fat diet. I do mostly carnivore-ish. I don't exclude plants like religiously. I just tend not to make them very much. But last night I had a salad, but I make my own blue cheese dressing with organic cream cheese, blue cheese, and some bone broth. Um, when I get up, so my daily routine is get up in the morning. First thing I do is I go down to my home gym. I've got a nice dumbbell set. I've got a couple cardio machines. I've got, like a nice exercise floor. So I'll do a HIIT routine. I'll do a lifting session. Sometimes it's a walking day and I'll just get on my treadmill and I'll just read a book while I walk. Um, I've got a few, if I've got a rower that sometimes I'll do a HIIT workout on. Most of the time I prefer more calisthenic HIIT workouts if I'm going to do them. And then I definitely like to lift heavy. So I do probably 2 to 4 days of lifting. It just depends on what program. I usually like to follow programs because I'm a very goal oriented. So if I have my plan, I like to execute my plan. I don't necessarily just want to go down there and go, what am I going to do today? Because that doesn't necessarily work great for me. So I always like to have a little plan. And then I can check off I've done this today. I also do have a full spectrum infrared sauna. So I tend to sauna 2 to 3 days a week. When I'm in town, I try to do 3 days a week, but I do travel back and forth to Florida and then around to meetings on occasion. And so if I'm around, I do it about 3 days a week. And then I try to get outside and walk a little bit out into the fresh air because now that I work at home, I could never leave my house. But I do have a dog, so we walk the dog and I'll go out at lunch and get some fresh air and bright light while I'm walking the dog, and we'll walk after work. And sometimes, or one of my nicer things is I do have a pool in my backyard, so I do like to be by water, in water, around water. I'm a water girl. I grew up in Southern California. I was a swimmer, age group high school, played water polo in high school and in college. And I did a number of years. I kind of did some triathlons or open water swims or things like that. And I live outside of Chicago, so I can get down to the lakefront. There were a few summers a while back. It kind of has not happened in the last year or two, which I'd love to get back to. And I've talked about it, but going down to the lakefront and swimming in Lake Michigan regularly. Um, so I try to walk the walk and talk the talk. I definitely have a very regimented bedtime routine. I am to bed early and up early. I love that. And all of my friends know. So if we're going out, like we're going out at 5 or 6 and we're home by 8 or 8:30, I'm not going to be out till 11. I am not one that wants to go out late. Or if we're going to dinner, you guys can go to the bar after dinner. I'm going home, so I really prioritize some of those things. And I will say that some people, don't like the idea that they have to say no. And I say, guy, it is an honor to get to say no sometimes. Like, I mean, it just, you're rewarding yourself. And I think that when you follow or you track glucose or ketones or any of those type or aura rings, how many people say, oh, yeah, everything's worse if I stay out late or if I have cocktails or even if I just eat dinner late? Like, I do so much better if I am consistent and this is how I live. And I think that my goal is to rub off on more people, right? So I do have people that, have given up carbohydrates or cut way back on carbohydrates, that are eating more real food, that are prioritizing health maintenance as opposed to, getting old. And I say, yeah, like, we don't have to get old. We don't have to be on 6 medicines. Like are, as we reach middle and later ages, like you don't have to, it's not normal. I mean, yes, it's normal because that's what the average person is doing, but it is not what should happen. It really is abnormal to our physiology.
Yeah, no, that's great. Thank you for sharing all that. So if someone is listening to this and almost everybody knows somebody with cancer and, they're like, why, we've got an oncologist, we're doing kind of traditional therapy. How would it benefit us to look into maybe some of these, I guess you call it alternative treatments, or more so complementary treatments as it pertains to diet and supplements and other things? What would you tell them?
Well, I would tell them that there's actually some nice data that if you combine like fasting or severe calorie restricted keto, which puts you into ketosis, around chemotherapy, that you tolerate chemotherapy better, that you might augment the effectiveness of therapy. There's some data that ketogenic diets with chemotherapy, those patients had far more responses, so partial and complete responses compared to the patient just getting the chemotherapy. There's data that adding vitamin D increases disease-free survival, like in stage 4 colon cancers. There's data that fish oil or omega-3s, high omega-3s, actually decrease chemo brains and neuropathies associated with chemo. So there's a lot that we can do to protect our normal cells from these very toxic agents while we are going through therapy. And in addition, maybe they make those therapies work better in the cancer because we're really pushing on the different metabolism of cancer cells versus normal cells.
Mhm.
So I think it's so powerful. Now sadly, not every patient is there mentally to do the work. I mean, I have some people who reach out to me and then they go, oh, you know what, never mind. I think I'm just going to focus on treatment now and I'll come back to you later. And you kind of like, oh, you're going to miss like the most powerful aspect of this in doing them together. Um, but it takes a lot of work on a patient, right? Because we're constantly like, if you go to a restaurant, is there one single dish, entree on the plate, any kind of meal that you get that isn't with carbs, with grains, with a bread, with a tortilla, with a side of rice or potatoes or noodles or whatever? Like you have to actively create meals or learn how to go out, learn how to plan ahead, learn how to bring your own lunch to work, cook. So many
Mhm.
people don't cook anymore. They just want fast food or pre-made foods or whatever. And luckily, there are some companies now that are catering to those people that you can buy low carb or ketogenic type option. Most of them are not high fat enough. So even if you buy a keto meal, I'm usually saying add 2 more tablespoons of fat to that. Um, but there are some convenience options out there, but I will say you will always do better if you shop for yourself and you cook for yourself.
Okay. Very good. Well, how can people follow you? I know your website is kessrx.com, KESSRX.com. Are there other ways that people can reach out to you or kind of follow you?
I don't do much on social media. I do a number of, the occasional interviews. Some educational courses are out there on my resources pages where I typically link things that I've done or I'm working on. Um, I don't really post much on social media. I'm probably mostly on X right now, but really I'm more of a follower. I like to follow the scientists that are publishing or discussing interesting articles. And so I'm on there more to educate myself and look at, oh, that's a super interesting graphic or trial or something that I could use as a teaching tool. But I'll repost things that I think are very interesting. And then if somebody wanted to schedule an appointment, they would do it directly from my website services page. The One of the issues is that there's not a lot of us out there, so wait lists are quite long. I do my best to move people up because certainly we have cancellations or reschedules, and I need someone to fill earlier slots. So I work hard to move people up, especially those that are in the throes of active cancer. But right now, my next available appointment is January,
Oh, wow.
and we're in September right now. So I'm out about 4 months. But most people I will move up 1, 2, sometimes even 3 months. So I don't want people to feel discouraged. Like if they're super interested in this, I say just trust the process, schedule the appointment, start working on paperwork. We'll get labs, and the likelihood is I will get you in earlier. I just can't guarantee anything because I don't want someone to be totally disappointed. But yeah, I mean, I have plenty of people who do that, and the ones that are like the most passionate tend to be the ones that get moved up because they are doing everything I want them to do, like doon, 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 and they're like, I'm ready. Like, tell me when you have a cancellation. I'm ready to go. And so those work out, I think, pretty well.
Okay. Okay. Awesome. And I think you mentioned you're going to be speaking on a cruise.
Oh,
Is that
so that
The Metabolic Health Society, or who is
Oh,
that with?
so no, the cruise is actually next June, or so June 2026. That's
Okay.
through the low carb cruise.
Okay.
And there's a number of metabolic health docs obviously speaking there, Dr. Tro and
Yeah. Yeah.
a number. But there's Dr. Nasha and that group, the Metabolic Regen, is doing a metabolic health day. So, sorry, a metabolic health conference in Tucson, Arizona, which is just next month. So early October, mid-October, the holiday weekend.
Hmm.
And I'll be on one of the panels on metabolic health.
Yeah.
There should be some very interesting speakers at that. And that's a little bit, I like it in that it's a little bit more broad. So a lot of times when we go to low carb conferences, it's very much low carb diet, low carb
Mhm.
diet, low carb diet.
Right.
Sometimes metabolic health, we see a little bit more in maybe in circadian biology or exercise and diet and other things. This one has, a regenerative farmer speaking and somebody that's more in the functional medicine and some that are in the metabolic health space. And so I think it's a little bit more of a broad group of
Yeah. Yeah.
providers and
Yeah.
people in the space. So it's
Good.
exciting that
Yeah.
it seems
Yeah.
like it's growing and there's more and more conferences and variations on those conferences. So I'm excited for the future for
Yeah.
sure.
Well, very nice. Well, as we wrap up here, I always ask my guests if they could give us one health tip that could make us healthier today. What would you say to that?
Eat single ingredient foods.
Amen. Yeah, that's a big one. Yeah.
Yeah.
Excellent. All right. Well, thank you so much for your time and for what you do. And again, I'll post her website on the show notes, but kessrx.com and Dr. Christy Kesslering. Appreciate you and appreciate everyone listening. And we will talk to you next time.